Well, I hope everyone enjoyed their break, and it was a very, very stimulating first panel. And I'm Dr. Paula Johnson. I am the chief of the Division of Women's Health and the executive director of the Connor Center for Women's Health and Gender Biology at Brigham and Women's Hospital, which is one of the major Harvard teaching hospitals. And it is my great pleasure this afternoon to moderate the panel on health, the impact of gender on health. And I think you'll agree, as you've read your programs, we have three really remarkable leaders who will give us different perspectives on achieving health from different perspectives, achieving health and looking at it through the gender lens. You have your programs, but I do want to give a brief introduction. First, to my immediate left, is Vice President Joyce Banda of Malawi. The Right Honorable Joyce Banda is Malawi's first Vice President. And I can say, after getting to know the Vice President through a prior visit and through this week, she is truly a leader of great magnitude. Her mission is to assist women and girls in gaining social and political empowerment through entrepreneurship and education. And she's founded or co-founded any number of organizations, and most importantly, in 1998, established the Joyce Banda Foundation that has really been very instrumental in her realizing her vision of empowering women and girls, predominantly through education. She has been a leader in decreasing the rates of maternal mortality in Malawi, and her talk today will be entitled Community-Based Responses to Improving Maternal Health in Malawi. Second will be Mirai Chatterjee, to my second left in the center. And Mirai Chatterjee, also a phenomenal leader, is the Director of Social Security at the Self-Employed Women's Association, or SEWA, which is a union of 1.3 million women workers in the informal economy in India. It was founded in 1972, and for those of you who know the organization, I think you'll agree, it really serves as a major international model of organizing women to give them a voice and the tools for self and collective empowerment in order to improve their lives. She's the chairperson right now of the National Insurance Vimo Seva Cooperative and the Lok Swasthya Health Cooperative. And a testimony to her leadership is that she was recently appointed to the National Advisory Council by the Prime Minister of India. And she is now on one of the major committees that will work to develop universal health care in India. She also happens to be a Harvard graduate. And her talk will be entitled Acting on Social Determinants of Health, Some Experiences of the Self-Employed Women's Association of India. And last but not least will be Dr. Kirk Smith. He's a professor of global environmental health and the director of the Global Health and Environment Program at the University of California at Berkeley. And he is among the world's leading authorities of the problem of indoor air pollution, which is a problem that disproportionately affects women and children, especially given its association with cooking. Dr. Smith has pioneered the sentinel studies on the impact of air pollution, indoor air pollution, on health. And in addition to the numerous international scientific advisory boards that he serves on, he participated in the Intergovernmental Panel on Climate Change's third and fourth assessments, and therefore shared in the 2007 Nobel Peace Prize. And I do want to say that in a 2009 New Yorker article that many of you may have read that described Dr. Smith's work, the authors make reference to a statement that his wife made, and I'm going to take the liberty of paraphrasing it. And what she said was that most men spend their lives watching women cook. My husband has managed to make a career of it. and his talk will be entitled "The Hearth Kills More Than the Sword." So thank you and welcome to all of you. And we will begin with the Honorable Vice President Joyce Banda. Well, Vice President Banda is going down. During the talks, what we'll do is at the end of each talk, we'll do the same thing that the first panel did, if there are any questions from the panelists to the speaker. And then we will also be collecting questions throughout this period. So at the end of each talk, just feel free to send your questions down to the end. Vice President.
Thank you. Good afternoon, distinguished ladies and gentlemen. It is a pleasure for me to take part in this conference organized by the Radcliffe Institute for Advanced Studies and the Women and Public Policy Program of the Harvard Kennedy School. I'm excited to be in this space discussing issues relating to gender in the developing world. Gender and development is where my heart belongs, because I've spent 20 years of my adult life working on women's rights and gender equality. My contribution to this panel today will focus on community responses to improving maternal health, and I will use my country, Malawi, as a case study. Malawi's response to addressing maternal health builds on a national motherhood program, Safe Motherhood, that the country established in line with the Global Safe Motherhood campaign. The work is guided by a national framework called the Roadmap to Reduction of Maternal Mortality in Malawi. The country has also benefited from the launch of the African Union Commission campaign for accelerated reduction of maternal mortality in Africa, KAMA. I was honored in the year 2009-2010 to serve as Malawi's Goodwill Ambassador for Safe Motherhood. And that is where I'll draw my experience from. The country's maternal mortality ratio is considered to be among the highest on the African continent, and it currently stands at 2008 out of any 100,000 live births. We are believing that with the efforts that we've made, the next figures will go down to around 600. This figure is on the higher side still, but of course it is worth noting that the country has recently experienced a considerable decline in trends in maternal mortality. In the year 2000, our maternal mortality ratio was as high as 1,120 per every 100,000 live births. Some of the contributing factors on the high ratio shortage of staff and weak human resource management. 2, limited availability and utilization of maternal health care services. 3, weak referral systems. And 4, weak community participation and involvement. As you can see, 3 of those factors contributing to high ratios are related to community involvement. This is therefore the justification for my argument that any viable maternal health program should seek to also invest in its understanding of how communities, their behaviors, attitudes, and beliefs are an enabler or an obstacle to attainment of positive indicators in maternal health. In Malawi, the maternal health program is being driven at 3 key levels. 1 is at the policy level, 2, service delivery level, and 3, at the service demand level. Examining the attention given to these levels, my conclusion as Goodwill Ambassador was that we concentrate more on the two upper levels, policy level and service demand level. Good initiatives are present at these levels, such as allocation of good financial resources to the reproductive health sector, multi-sectoral planning, retention of health workers, training of health workers, and building of health facilities in both rural and urban places. However, during my tenure, I noticed that there was a low investment in engaging with communities at the service demand level. This was evident because I went around visiting the country as Goodwill Ambassador, and I noted the following among other things. Low community knowledge of the importance of pregnant women giving birth at health facilities with the help of skilled attendants, vague understanding of new role of the traditional birth attendants as referral, low male involvement, poor utilization of traditional leadership as change agents, high teenage pregnancies and low prevalence of communities, motivation to challenge some of the negative and harmful traditional and cultural practices. And finally, underutilized maternity waiting shelters for women. This was not making sense because in any case, the level where the clients are, the community level, is an important part to reduction of maternal mortality. I say it is an important part because while the policy might be right and the supply of service is ready, if care-seeking behavior are not stimulated and sustained, the goals of maternal health may not be realized. I'm sure we have heard that about the delays that women largely face in their pregnancy and childbirth. Two of these critical delays, the delay in making decision to seek care, and secondly, the delay in getting to institutions can jeopardize the life of an expectant mother and the unborn child. Apart from that, socioeconomic and cultural challenges contribute to poor or bad health-seeking behaviors. Therefore, communities are an important aspect of any safe motherhood program because our planning of effective intervention should aim at addressing these community obstacles. Realistically, though, community-based interventions have not necessarily received the same level of attention as facility-based interventions, and this is a gap. And yet, evidence has shown that where communities are mobilized and have taken ownership of safe motherhood, positive results are yielded. Building on some of the successes that were already evident as a result of involvement of communities addressing maternal deaths, I launched a very successful nationwide campaign to ensure that we stimulate community participation in reducing maternal deaths. Some of these initiatives included sensitization workshops of traditional leaders and chiefs on their role as change agents to ensure their communities encourage women to give birth at health facilities. As a result of this sensitization, some chiefs set up bylaws that prevent any woman from giving birth at home or at the traditional birth attendants. Some chiefs also formed senior women's groups that mentor younger pregnant women and encourage them to do all antenatal clinic visits and also have a plan for childbirth preparedness. Motivation of women to utilize, where available, the maternity waiting shelters, especially for women coming from distant villages, was also encouraged. Mobilization and motivation of traditional birth attendants to embrace their new role as referrals for pregnant women to health facilities. We also paid a lot of attention in male involvement programs, challenged to modify some negative cultural practices, and we also strengthened the referral system between health workers at facilities and their communities through establishment of village committees on maternal health as entry points for health workers on community initiatives and innovations. These are some of the successful examples, and all this yielded overwhelming positive response by the communities. It really supported my notion that if communities are involved in planning of maternal health programs, we can achieve more. And in order to support the demand that I created through the campaign, I then engaged the Ministry of Health, donors, and private sector to allocate and contribute more resources to maternal health. I therefore subscribe to the notion that in any maternal health program, attention should be given to working with communities and ensuring that they are an integral stakeholder in promoting safe motherhood through changes in social cultural behavior that impinge on maternal health, motivating communities to adopt positive practices in safe motherhood and facilitating flow of vital information in reproductive health. While I've been here over the last few days, I've also had discussions with many friends, some that are present in this room, on the need for us as Africans to also identify the role that women play at all levels as health workers. I'm thinking about us as women, African women at grassroots level, giving care, providing care for the sick, working as home-based care in the community, serving on the village health committees, and girls, particularly orphaned girls, missing out on school because they are caregivers to the sick at household level, traditional birth attendants, cleaners at the clinic, at the community clinic, and 90% of the workforce at the hospitals are women anyway. I was requesting some scholars here that perhaps time has come for them to assist us to document, to go out and find out and quantify how many women are participating as caregivers or health workers, including myself. I don't need to be a doctor, but we are really playing an important role, including the community leaders themselves. I thought that I should finish my presentation by sharing a story of how we can all work together to end maternal mortality, or indeed HIV and AIDS at grassroots level. There's an example of a partnership that emerged in one day. I was watching television, and there was a workshop of chiefs in one area. It was organized by the Hunger Project. The Hunger Project is an organization that gave me an award in 1997, and I asked them to come and establish that organization in Malawi. And they were running workshops to try to fight HIV and AIDS. And at that workshop, the presenter was talking to the chiefs to say, I'm sure that you don't take our young girls and boys for initiation anymore, because it is at these initiation ceremonies that the girls are brainwashed, the girls are also abused, sometimes sexually. And the chief said, no, but unfortunately for the chief, there was a young girl sitting there who said, no, you are lying. You just took me for initiation last year. At that point, a colleague of mine called and said, I hope you are watching. I was then a cabinet minister for women and children. I said, yes, indeed, I'm watching. And together with the Minister of Home Affairs, who was responsible for the police, who was also a woman, traveled with me the following day to attend that workshop. And when we got there, we had the opportunity to interview the children. But to cut a long story short, at the end of it all, the chiefs confessed and promised, looking at us and the policemen that surrounded us, that they were not going to do it again. But also the chiefs, together with the Hunger Project, formed a club of the young children who had confessed, because by the end of the day, they had something like 30 children who came forward with their stories about how they had been forced to go for initiation. The children formed a club and started going around in other schools to tell other children that it is all right to speak when you are being abused. And so, since then, the Hunger Project, government, and the chiefs in that area have formed a strong partnership to ensure that our children are not abused anymore, and not only that, that we stop the spread of HIV/AIDS. From this, we can see that across the board, local leadership can be used in girls' education, in health, in disseminating any kind of information. The moment you win over the chief, you have won over the whole community. Thank you very much for your attention.
Thank you, Vice President. And I'm going to ask Mirai and Kirk if you have any questions for or comments responding to the Vice President's remarks.
Thank you very much, Vice President Joyce, Sister Joyce. I think a lot of what you said really resonates with our own experience in India and in Asia. Unfortunately, our maternal mortality ratio is still 300 per 100,000, and in some areas double of that. So we also have a long way to go. I'm particularly interested in asking you and learning more about the community-based approach, particularly the involvement of the traditional birth attendants. Because like in Malawi, so also in India, about 60% of the births are still performed, home deliveries, home births, by traditional birth attendants. And we haven't found a very good way, I must say, to involve these women in actually working more on health issues and on maternal deaths. So we'd like to learn from you some more.
Yeah, I think in the case of Malawi, the chief is the hub, and all these traditional birth attendants are living within that community. And whatever the chief says, the community shall follow, including the traditional birth attendants. And so for us, we target the chief. The moment the chief is sensitized and accepts the concept, then it is the chief who will tell the traditional birth attendants, and even charge a fine if the traditional birth attendant goes out and delivers a child. What then the traditional birth attendants have turned out to be is they are now the referrals where the woman, when she's pregnant, there are two opportunities for the woman, because traditionally, a woman is not supposed to tell anybody else that she's in labor except maybe her mother or her mother-in-law. What the chief and us have done is to ensure that she has other people she can go to, and that is the traditional birth attendant and what we call secret mothers. So they know now that even if my mother is not here, I can go to that lady, and that lady can help me, can advise me, can take me to the clinic, as well as the TBA. What we have been looking at, together with some members of staff of Partners for Health, I don't know if Dr. Joy Chatterjee is here, but she's been working in one area in Malawi where we want to pilot a project where we mobilize the TBAs, but we must also ensure that they are compensated for their loss of income, because for them it's an economic activity, to ensure that they are compensated so that they can continue, they can be motivated to continue as referral for pregnant women at grassroots.
Thank you.
So a very important testing of a model that doesn't take a traditional birth attendant and take their role away, but changes their role and remains and obviously honors that very important role that they play in the community. Vice President, can you just tell us a little bit about, your work in mobilizing the grassroots of women and you've worked a lot on economic empowerment and how that has really helped women gain stature and has really also helped you achieve some of your goals when it comes to health?
Yeah, I must first acknowledge SEWA because in 1992, I was sponsored by the US government to go to SEWA in India to spend some time and to Grameen Bank before I came back to start the microfinance program in Malawi. So I shall forever be indebted to Ella Bhatt, who is the founder of Self-Employed Women's Association of India. We find that in Africa, in most communities in Africa, the men are not at grassroots. They are in town, they are educated, they are doctors, they are teachers, but their sisters are back home because when resources were low at household level, the boys went to school, the girls didn't go. So the National Association of Business Women that I founded targets those women by providing microfinance training and information. We started out thinking we were just starting a club of 100 women. It's now a national organization of 50,000 women. And because of that huge platform, we also decided to take on safe motherhood, distribution of family planning devices, teaching the women about their rights and reproductive rights. And as a result, it's the strongest rural network of women that have taken on issues just other than economic empowerment. But as I've always said, it is economic empowerment first. It is in a study that we conducted in 1998, funded by USAID again, we found that women, 73% of those women had come out of poverty forever. But what was more significant was that 84% of the women that we had assisted, that were members of the organization, had earned respect at household level, and now we're contributing to decision making at household level. They were even allowed to make decisions about themselves. One woman said, when you said that to me, to say the day that I earn economic empowerment, I will first feel it at home, at the household level, because I'll earn respect for my husband. She said, Mrs. Banda, I didn't believe it. But you know what? When I came, I attended training, I got credit, $100, I started my business, and for the first time, I bought a kilo of meat for my children at home. When my husband came back, my children had eaten. And after a few months down the road, it is my husband who told me, you can't have any more children. 8 children are enough. You are very busy now. Yeah, so you find that with economic empowerment, then comes that power, that respect at household level. You begin to make decisions that affect your life and then contribute to decisions at household level because you're adding value to the household. But also family planning, things that concern your health. You can even negotiate for safe sex. You can negotiate for how many children you will have. She told me that if it was 2 years ago, if I had told him eight children are enough, he would have beaten me up. But when it was him now telling me 8 children are enough because you're busy. Thank you.
Thank you very much. We'll have Mirai Chatterjee next.
Namaste and greetings. Thank you very much for this opportunity to share some ideas and experiences. The Self-Employed Association SEWA is a union of 1.3 million women workers in the informal economy in India, spread across 9 states. Our members are street vendors, they're home-based workers, they are small producers like artisans, craftswomen, and they are, a large chunk of them, manual laborers and service providers like agricultural laborers, small and marginal farmers, and domestic workers. 94% of the Indian economy is informal, and women workers are mainly informal. Women work long hours for very low wages and income. They have no fixed employer-employee relations. They don't enjoy basic statutory social protection like sick leave, maternity leave, and social security benefits. In fact, theirs is a lifelong quest for work security, income security, food, and basic social security like healthcare. It is the labor of more than 400 million workers, women and men in our country, that is currently powering the high growth, the 8% growth of the Indian economy. In fact, their contribution to India's GDP is to the tune of 60%, and to exports, the contribution is 47% and 55% of national savings. And just for those of you who are not familiar, in the photograph there is one of the women who are powering the economy. She's producing salt in one of the districts, and they're among the poorest of SEVA's members. Despite their significant economic contribution, informal workers remain in poverty. In fact, more than 50% of India's people, unfortunately, are still below the official poverty line, and some estimates are as high as 70%. Women are the poorest of all informal workers. They work long hours and in occupations and trades that often their men will not do, like growing and processing tobacco. They also face many socio-cultural barriers and discrimination in our still deeply patriarchal society. So they are most often excluded from decision-making and leadership. SEVA has been trying to address these issues since it was founded in 1972 by Ila Bhatt, a lawyer and labor organizer from the city of Ahmedabad in Western India. But what we found was, while our members are very poor and excluded, they are very ready to lead their families and communities out of poverty and towards self-reliance. Over the past 40 years, we have learned that work is central to the poor, very much what Vice President Banda was saying, the whole issue of economic empowerment. So work is central to the poor, and particularly women. No matter where we go in our villages and in our working class urban neighborhoods across the country, we hear, give us work, any work, we're ready to do any work, because work is our lifeline to survival. Work is how we feed our children and offer them a better future. Hence, SEVA began organizing women around work. Better wages for home-based workers, 2 baskets worth of space in the marketplace for street vendors, and working capital for small farmers, artisans, and others. But we also learned that work alone cannot help our sisters out of poverty and towards self-reliance. Some of our best teachers were our earliest members, the street vendors. The street vendors in a community called Shankar Bhuvan, they live, it's a vibrant community living on the banks of the Sabarmati River that flows through Ahmedabad city. They are hardworking and feisty women, very lively, selling scrap metal, fruit, vegetables, and spices from push carts in the streets of the city. Before they were organized into their own union, SEVA, they were harassed by the police and municipal authorities. They were routinely evicted, told they were a traffic nuisance, and fined heavily. Their goods were confiscated and destroyed. Once they joined the union, the harassment abated somewhat. They also helped to start up their own women's cooperative bank, SEVA Bank, way back in 1974. They saved, took loans to build up their businesses, repaid those loans, took more loans, and built their businesses, repaired the roofs of their houses, and so on. But we found that many of our sisters suffered from tuberculosis, leukorrhea, their children routinely suffered from diarrhea and pneumonia, and much more. The women told us their turn to bathe came once in 4 days because of limited water supply, and the riverbank was their toilet. They said, we work night and day to feed our families. How can we ever be healthy if we live like this? Whatever we earn goes in doctors' bills and medicines. They demanded that SEVA, their union, begin a health program and asked, first of all, for health information, life-saving health information and health education, simple do's and don'ts. Some of them then went on to become the barefoot doctors of their communities and later encouraged their rural sisters to do so as well. Together, they formed India's first health workers and traditional midwives cooperative. They negotiated with the Ahmedabad Municipal Corporation for toilets and for better water supply, ensured that all their children were immunized, and that their neighbors recognized the early signs of tuberculosis. From our Shankar Bhuvan street vendor sisters and our other members, we have learned much. We have learned that while work is central, women need much more. They need full employment for their ultimate goal to emerge from poverty and towards self-reliance. And that is also what Mahatma Gandhi, who is the inspiration of Seva, taught us, that we have to work on all fronts, the holistic, if we are to lead our people out of poverty and to hold their heads high. By full employment, as you can see in the slide, we mean work security, income security, food security, and social security. It is a composite concept, and as you can see, social security in our experience at Seva is at least healthcare, childcare, insurance, pension, a roof over her head, and basic amenities like a tap and a toilet. And self-reliance is both in terms of financial sustainability and also decision-making control of the woman and her organization. Our experience has pointed to the need to organize women on all these fronts. We've been doing this through building up membership-based organizations of women. And generally, work has been the starting point. But we've also found that health, daycare, childcare, urban services, insurance are also very good entry points for organizing poor women around their needs and issues. And over the last 40 years, we have organized women from 200 occupations and trades into more than 3,000 small, medium, and large membership-based organizations. Just to give you a glimpse of the different forms of organization that we have experimented with and worked with. First of all, union. We started out as a trade union. We still are. We are now a national level trade union, the largest women's trade union in India, but we've also promoted unions in different states. Then cooperatives, more than 103 cooperatives, which are collective businesses of women. The largest, of course, is our women's urban cooperative bank, Seva Bank, which today has more than 300,000 depositors and over $30 million as working capital. Then there are the social security cooperatives, which I will be speaking about a little later, Lok Swasthya or People's Health Cooperative, and our National Insurance Vimo Seva Cooperative. In addition, we have formed dairy cooperatives, fish workers cooperatives, landless women's cooperatives, where landless women cooperatively farm land and feed themselves and their families. And all of these cooperatives are then in a state-level federation promoted by Seva. Then district-level associations, village-based associations of micro-enterprise groups. And then similarly in the cities, community-based organization in different urban working class communities, 80 of these, which are then federated into a citywide federation that works on urban basic services like providing taps, toilet, garbage removal. And in fact, the women then get work. The municipal authorities have now handed over the work of garbage removal and maintaining taps and toilets to local women and their families. And finally, workers' companies, artisan companies, companies for marketing rural women's produce, and also construction workers. Our experience points to the need for such membership-based organizations of the poor if women are to attain their goals of full employment and self-reliance. Also, through these organizations, when they come together, they bounce off ideas, and lots of creative and constructive ideas for action, like developing their own health insurance, emerge. I would like to focus briefly on two such organizations, two of the cooperatives. One is the Lok Swasthya Seva Cooperative. It was formed because women said our bodies are our only assets. If we can work, we can survive. As long as we are healthy, we can work and earn and feed our children. And also because despite having a public health system, it's improved somewhat in the last 2 or 3 years. But 30, 35 years ago, we had a non-functioning public health system and a private system, which is very much there, but is extremely expensive, and women often have to go to money lenders to pay doctors' bills. So it was the women who said, let's form our own cooperative, let's take care of our own health. It took us 2 years to register this cooperative because the registrar of cooperatives said, what is this kind of cooperative? A whole bunch of illiterate women and midwives? How can you have such a cooperative? And that too, the women had barely been to school. But I think we just kept at it for 2 years and they got fed up seeing us every day and, well, gave us our cooperative. So 2 decades later, this Lok Swasthya cooperative now has close to 1,000 shareholders. The women pay up share capital. And about half of these women are getting work and employment as health workers full-time. 15 of them are elected to the board of the cooperative, and they represent different districts and trades. Today, Lok Swasthya Cooperative is categorized as an A-grade cooperative by the same cooperative department, which was reluctant to give us registration in the first place. Collectively, the members provide simple health information, as well as more in-depth education to their sisters and communities, sell low-cost medicines because we found that drugs was the #1 cost for poor women, which was driving them deeper into poverty. So selling low-cost medicines door to door, and then reclaiming our traditions through manufacturing our own Ayurvedic medicines and selling these. So all across the value chain, some women grow the herbs, others actually process them and produce the medicines, and still others sell them and make a living from this. We also run a tuberculosis control center with barefoot lab technicians, the daughters of our members, and 10 satellite centers in different neighborhoods for sputum collection and dispensing free drugs provided by the government. Then women said we need health insurance. This health education and preventive work is all very well, but we do end up in hospital, and what then? So we developed in a situation where there was no health insurance for the poor, or microinsurance as it's called. We developed health insurance and also facilitated linkages between women and government and private health providers. One of the things that connects to what Valerie said was monitoring policies, health policies. We do have a policy and legislation in place that outlaws prenatal sex determination, but implementing that is a challenge. So women keep their eyes and ears to the ground and try to make sure that these tests are not undertaken. The second experience is that of our insurance cooperative, the National Insurance Vimo Seva Cooperative. We got the idea of insurance again from our sisters, because when women were banking with Seva Bank, they said, we put in our savings here, our hard-earned money, but one sickness, one death of spouse, and we're wiped out. We have to not only use up our savings, we have to mortgage our land and pawn our jewelry. So it was the women who pushed us in this direction, and we met with the large insurance companies who, like they told women, you're not bankable, they told us you're not insurable. You're just bad risk. Women die too much. Women die of maternal causes, maternal deaths, and you're not insurable. But anyway, we persisted, and when Seva's membership strength was 50,000, that's when the insurance companies got interested. Now we link women with insurance companies. The regulations still won't allow us to be a full-fledged insurer. We need some $30 million just to get the license. That's because our government, they only think of big insurance. They don't think of micro-insurance. And they certainly can't imagine that women can run insurance. But anyway, that's another remaining challenge of ours. So now we link with the insurance companies, and we help them negotiate good services and at an affordable price. The shareholders of the cooperative are all women, and they are also, like the health cooperative, elected to the board and run their own cooperative. The other point I'd like to make is that the services that are provided by local women. We call them Vimo Agevans. So as you can see in the slide, they do the education, they do the premium collection, and they also do claim servicing. And of course, in dollars, it doesn't look very much, but we have collected this year 13 million rupees as premium, and this has gone towards insuring women. And of the 100,000 policies sold, 60,000 policies are just of the women themselves. We still have a long way to go. We have lots of stops and starts and struggles along the way. But one thing that has happened recently is that our government has started a national health insurance program for below poverty persons, and it's modeled on our Vimo Seva cooperative. Finally, over 4 decades of organizing women for their well-being and for their health and for self-reliance, we've seen that it's important to undertake 4 courses of action. One is organizing for voice and representation. I can't emphasize this enough. If there's one thing we can share with all of you, it's the importance of organizing. In all our societies, and certainly in a country like mine, it's impossible for women to fight against injustice and inequality alone. Through the sisterhood, through the collective, she's inspired, she gets strength, she gets courage, they stand by her, and slowly, slowly, she begins to fight for change within the family, in the community, and society at large. And as I've already mentioned, uniting and building membership-based organizations of the poor, we have found democratic economic organizations. This is key. I would say that whatever gains all these years Seva has achieved, it's entirely due to organizing, and when women have taken up the leadership and built their own movement. Of course, it's not easy, and more so in a country of 1.3 billion. We have a long, long way to go, and we are a very diverse people with multi-religious, multi-ethnic, multilingual, multi-everything, so it's a huge challenge. The second is financial inclusion, which I've already spoken of, integrated financial services, not just savings and credit, but also pension, insurance, and financial literacy, so that within her small budget, she learns how to manage her family finances better. Social security also, you saw the earlier slide, at least healthcare, and we say universal healthcare. And if I may just interject here, I think it'll be interesting for American friends and others that in our country there's no debate on this. We're moving forward for universal health care for all, and by June we will have a blueprint, which we hope to share with you and with others and the world community, if it's useful. And just to give you a hint of what we are thinking, we have suggested to our government, and amazingly they have agreed, that they treble the public health expenditure, and 70 to 75% of that will be spent on primary care. Capacity building is the 4th course of action, both to enhance technical capabilities, our management capabilities, and our leadership. The important point is that all of these need to be acted upon simultaneously. It does sound like a lot, it does sound like a tall order, but we really have to work at all of these. One by one or only one really doesn't make sense. Further, and in conclusion, in all of these efforts, we've seen that women are very much ready to take the leadership, and when they lead, something very powerful happens in their communities. And Vice President Banda has also referred to this. When women workers lead, we find in India and South Asia, they ensure that the poorest are included and that the whole family benefits. Increases in women's income, this is very well documented, usually translate into more and better food, schooling for children, and other essentials. Women are also future-oriented and create sustainable organizations. They nurture and develop young leadership, new leadership, and also develop different models of leadership. We find they are the drivers of change, slowly transforming their families and communities while retaining some of our traditions and customs. Somehow, women have a way of organically working from one issue to another, linking them up, and seem to have a deep understanding of the interconnectedness of different aspects of their lives. The holistic approach comes naturally to women at the grassroots level. Perhaps this is because of what they live through every day and the struggles they face every day. Today, these different aspects of our well-being are called the social determinants of health. And there is a World Health Organization commission of the same name, which studied these determinants and brought out a landmark report, which many of you would be familiar with, called Closing the Gap. It's about equity in health. I think for my Seva sisters, and I suspect millions of women in other countries and other continents, they have been already acting on these social determinants. They didn't know they were called the social determinants, but they were acting on them and will continue to do so. Perhaps the need of the hour is to share, learn from each other, and build alliances, as we are attempting to do here. And I think this is the way forward, and this will ensure health for all women and their families on our planet. Thank you very much.
Thank you, Mirai. Do any of our other panelists have a question or a comment or response to Mirai? No? Mirai, I'm just going to say thank you. As visiting with you, you were so generous and kind to host me last May. I would say the voice of the women, that empowerment is truly palpable. As you think about the generations of women who have now come through Seva, you now have the daughters and some granddaughters. What do you see as the trajectory of these women who have been in the organization, and as they branch out?
Well, now the mothers and granddaughters and the daughters are very keen to enter the new sectors of the economy because they see a growing India, they see opportunity for about maybe 10 to 15% of our population and opportunities that don't reach them. So one of the major areas that they are looking to is skill development and learning new things like computer operators. So we have traditional applique workers who are also learning to be computer operators. So I think a major direction for our younger sisters is how they can enhance their income, very much like what Vice President Banda said. For them still, the economic is critical. We've not been able to, unfortunately, after 60 years of independence, provide our people with the basics, water, and what we in our language say roti, kapda, makan, which is, bread, clothes, and just a roof over your head, really basic stuff. Yeah. And I think the women and the younger women see that the way out is through education for a start, and also education linked to employment, skill building.
Thank you. And hopefully we will, maybe during the question and answer period, have some more discussion about your new universal health care policy and how some of the needs of women are going to be addressed through that, and maybe do a little comparison with the United States as well. Next, Dr. Smith is going to talk to us. The hearth kills more than the sword.
Well, it's a pleasure to be here and an honor to be following these really inspiring presentations. Another aspect of watching women work, I guess, but for me. But I'm going to shift gears a little bit and talk about a risk factor that mainly affects women. But first I wanted to know if you'd seen the New York Times website. Let's see. Here, middle of the Egypt thing, it says here, toxic tsunami threatening U.S. women's health. Evidence indicates that a wave of toxic material will soon be affecting U.S. women, as half of all households to be exposed, thousands likely to die. Now, what was in this story? Let's see. This is this toxic soup of chemicals has mutagens, immune system suppressants, severe irritants, blood poisons, inflammation agents, central system depressants, ciliatoxins, endocrine disruptors, and neurotoxins. It also several chemicals that cause cancer, and other toxic inorganic chemicals known to cause heart disease, infant death, and lung disease. It will be the result of a process that pours this toxic soup directly into half of all U.S. homes every day, all year, every year, but only when women are present. It will expose the women to toxic levels much higher than those living on the top of toxic waste dumps, working in the dirtiest industries, or residing in the dirtiest cities. These toxic levels will be tens or hundreds of times greater than they've been set by national and international organizations to protect health. So what would happen? Or excuse, why would it happen? A technology be widely promoted that takes a perfectly safe natural material and converts 10% of it to toxins in the course of functioning, sometimes as much as 20%. Extremely low efficiency and benefit from this process. Instead of carefully disposing of the toxic materials that spread around in the neighborhoods. All of this, in spite of there being well-known alternative technologies available, producing very little toxin. What might be the health consequences on women if this were to happen? Well, thousands of women would have their breath taken away from them as their lung function is slowly eaten away by exposure to the toxins. Tragically, young ages, they're unable to breathe normally or do common tasks. Patients to protect health. So what would happen? Or excuse, why would it happen? A technology be widely promoted that takes a perfectly safe natural material and converts 10% of it to toxins in the course of functioning, sometimes as much as 20%. Extremely low efficiency and benefit from this process. Instead of carefully disposing of the toxic materials that spread around in the neighborhoods. All of this, in spite of there being well-known alternative technologies available, producing very little toxin. What might be the health consequences on women if this were to happen? Well, thousands of women would have their breath taken away from them as their lung function is slowly eaten away by exposure to the toxins. Tragically, young ages, they're unable to breathe normally or do common tasks. Once a woman is affected, there's no known medical therapy to reverse the process. More than 500 a week in the United States, 25,000 a year would soon start to die prematurely because their lungs would finally give out. Anything else? Well, there are strong indicators that the burden on women would include many other diseases, including heart disease, cancer, damage to the eyesight, and an increase in tuberculosis, all serious diseases. What should the response be? Full-time coverage on CNN and all other news outlets as the disaster unfolds? Major effort coordinated by the National Guard to protect the country? Emergency legislation in Congress to provide funds for cleaner technologies? New laws and regulations to make sure it never happens again? No, I'm afraid not. Nothing will happen. No one will notice. Now, you know I made this up. This wasn't actually a story in the New York Times here. It's the usual stuff in the New York Times. So don't go look for it. But everything I stated about the toxic tsunami, admittedly in a kind of alarmist terms, but completely justifiable, except for three aspects, important aspects, of course. It's already happening. It isn't something that's going to happen next week. It's been happening for, well, since the discovery of fire. It's not half of U.S. women, but it's half of the women in the rest of the world, and particularly the developing world. And no industry is responsible. It's poverty, complacency, maybe ignorance, but you can't blame it on the tobacco industry, the oil industry, or something. And of course, what I'm talking about is household pollution from burning simple solid fuels like wood and crop residues, animal dung, and so on, that is basically almost the definition of poverty. If somebody emailed you from Mars and said they're going to visit the U.S. tomorrow afternoon and had only 2 hours and wanted to see poor people, how would you tell them to find the poor people? Tell them to go look for people who are using solid fuels for cooking. Those are the poor people in the world. That's the half of the world. The other half, the ones that we don't live in, the half that we don't live in this room, those are the people using these fuels. So it's a sin, if you will, of omission, not commission. We haven't caused this to happen, personally. But nevertheless, it's still killing 1.5 million women and children a year. And thus, if we could add another bar to Dr. Hudson's graph on where she had the 20th century sometimes called the deadliest century because it killed more people in armed conflict than any other century. And there are these missing women that are roughly the same size. This is roughly the same size too. The 20th century killed as many women roughly as did armed conflict from the hearth. So that's why the hearth could be looked at as deadlier than the sword. Actually, the expression in a German parable is the kitchen kills more than the sword, but that refers mainly to overeating, I think, not to the hearth. And of course, here's where it is in the world. It's in the poor parts of the world, sub-Saharan Africa and South Asia in particular, is where a large fraction of the households are using these fuels. Now, some people say, well, how can wood smoke hurt you? I mean, it's natural. It's been around for a long time. Well, I remind you, that malaria is natural, and snake venom is natural, and, a whole range of nasty parasites in tropical areas are natural. I mean, arsenic is natural. I mean, in fact, it's a rather weird idea that you could go to a store and something's called natural and you're supposed to think it's good for you. Not only benign, but good for you. Actually, most of humanity has spent most of human history protecting itself against the natural, and this is an example. These are the nasty things found in wood smoke, and we don't need to go through them here, but a long list of nasty chemicals. The ones in italics are identified toxic materials, where I got that list of descriptions, including some standard air pollutants like small particles and so on, but a vast range of other things, including, you'll see at the bottom, dioxin. We've been doing measurements in our site in Guatemala, and the women and children there get high levels of dioxin by comparison to industrial cities. This is very similar to the mixture. What's the most well-known biomass smoke mixture in the world by far? Well, in the health field, if you ever have somebody asks a question you don't know the answer, a good guess is tobacco. It's almost always right. So it's very similar to the mixture in tobacco. After all, it's incompletely burned biomass, isn't that? That's what biomass is, tobacco smoke is. Now, there's some differences. There's not much nicotine in wood smoke. I dare say the world would be a different place if there was nicotine in wood smoke. The good news would be there'd be no tobacco companies. The bad news, there'd be no forests. But so, in any case, do you get a lot of air pollution when you burn this stuff in this way and release all this stuff? Yes, you do. I won't go through it, but you can see the kind of levels you get inside are much higher than standards, as I mentioned before. These, for example, these two particular chemicals are class 1 carcinogens, definite human carcinogens, as established by the agency that does such things. We tend to use small particles as the best indicator of the health impact. So how much ill health? Now, I like to show this picture. This is also quite near Ahmedabad, which is the source of much of the innovations in India, actually. The first person in human history to have exposure measured during the oldest task in human history. Now, am I exaggerating here? Well, what is the definition of becoming human? Anthropologists, archaeologists say that one good definition of the moment we became human is when we learned to control fire. And so this is the oldest task in human history, and it's always been operated by women, almost all. Let me ask you a question, in fact. I'll ask the women here. The men, don't tell the truth on this one question. Mostly women here. How many, you've eaten almost every day of your life. Somebody's cooked for you, or you've cooked for yourself. Who has had most of their meals cooked by men over that time? Well, that's interesting. Over the entire life. Over your entire life. One person, I got to talk to that person. Very rare, anyway. Women do the cooking, although men, occasionally do cooking, and maybe that's changing. Let's hope. I don't know. So, what are the health effects? I won't go through in great detail here, but we know quite a bit about it. There are, of course, impacts on the young children too, because they do their caregiving role. The young children are with the women during cooking. So, ammonia in young children, chronic obstructive lung disease in the mother's, lung cancer. That's the status of this around 10 years ago, but we are now updating, and that resulted in this 1.6 million premature deaths a year. making indoor air pollution the 10th most important risk factor in the world for all ill health, at the top being malnutrition, unsafe sex, the HIV epidemic, you can see blood pressure, alcohol, unsafe water and sanitation, and so on. A big player on the global scene. Fourth, in India. This is for the whole world here. So we're actually more important in developing countries. That this is, in terms of percent of lost life years, a better metric for ill health than just deaths. But if you like deaths, it's 1.6 million premature deaths. But we now know a lot more, and this comparative risk assessment is being redone for publishing this year. We have good evidence on a whole range of new risk diseases, including cancer. There's even evidence now on cervical cancer, blindness, cataracts. I'll show a little bit about that. Heart disease, and some other impacts on children. Here, for example, this is a little bit technical, but this is shows the meta-analysis. So they took all the studies on chronic obstructive pulmonary disease, combined them together in a statistical analysis, and came up with an estimate that is 2.1, which means that, and it's statistically significant, that means that women who cook over dirty fuels for long periods will end up having more than twice as much COPD as other women. Here's an actual intervention study where they introduced improved stoves in China, and you can see a big difference in the amount of chronic obstructive pulmonary disease in women over time, those that had the improved stoves and those that didn't. Cataracts. Now, people sometimes don't think of cataracts as a major burden of disease. It actually is. In South Asia, 2.8% of all healthy life years are due to cataracts. That's half the impact of ischemic heart disease, the major source of heart disease. Roughly the same as TB or stroke, larger than COPD or maternal conditions. So a major impact. And women suffer 40% more than men. Why should they? The main risk factors that have been talked about in the past are ultraviolet light, that is, working outdoors. Well, women do that too, but men do more. Tobacco smoke. Women don't smoke that much, men do. So what other risk factor is there? Well, I won't go through the arguments here, but there's quite good evidence now that it is cooking with biomass with solid fuels that explains the excess of cataracts in women. Here it shows the same sort of analysis that about women who cook over open fires for long periods, about 2.5 times more cataracts than women cooking with cleaner fuels. There's also women who are exposed during pregnancy, that affects their unborn children. And as we know, the women who smoke during pregnancy, the worst thing you can do with biomass is stick it in your mouth, right? The next worst thing used to be thought was to have somebody else sticking it in their mouths near you, passive tobacco smoking. But actually we know there's a middle group, and that's having it in your kitchen burning. So it's a higher dose than secondhand smoke, but of course lower dose than smoking itself. And when we look at women who are exposed during pregnancy, that the impact on their babies is about 90 grams, then they're using dirty fuels, their children about 90 grams less, way less. And why would 90 grams matter? Well, it matters a big amount because you get kids below about 2.5 kilograms. It makes a big difference in terms of both childhood mortality, and now we're recognizing long lifetime illness if a child is born at low birth weight. And India, for example, still has, depending on whose numbers you look at, a third or so of its births are low birth weight, maybe 40%. It's a very refractory thing. It's been very difficult to get at. And perhaps this is a risk factor that we ought to be looking at more carefully to try to deal with this low birth weight situation. It's not directly on the women, but of course they are the ones that have to care for the children that are sick and so on. So this is a perfect storm for health effects. It's a highly polluting activity, half the world's households, several times a day, just when women, are present, and the most vulnerable group. One way to look at this is the intake fraction is high. That's a jargon term in environmental health. That means that the fraction of material that gets into your lungs versus the fraction that was emitted is quite high. And of course, you know what the activity that has the highest intake fraction, But having the stuff in your kitchen also has a high intake fraction. So that's why a relatively small amount of pollution from this fuel can produce a huge impact. Of course, an even smaller amount of total pollution from cigarette smoking also produces a big impact. So we live in a world with a lot of disparities. I mean, just the disparity and the inequity, or however you want to look at it, of maternal mortality is just, astonishing, huge scandal. 500 times greater infant maternal mortality or something like that in Africa than in Europe, for example. I don't know if you know these photographs. Illustrate this in to me, a very stark way. This is food for a week. So this German photographer went around, had everybody in the households put out their food for the week in different parts of the world. And this was food for a week in this family of 4 in Germany. It's astonishing to look at, isn't it? And here's food for a week for a family of 6 in Darfur. Now, this is another very visual way of illustrating the disparities in the world we live in. And of course, women tend to bear the brunt of those, or the impacts of that. So one of the problems with this New Yorker article is that people have heard my wife's joke. But so I've turned it into a question, but it's based on my wife Joan's joke. So her joke goes, men have been standing around the kitchen watching women cook since the control of fire 1 million years ago, but my husband was the first one to make a career out of it. But then the question is, why is that? And why is nobody paid attention to this? I mean, we're now understanding this is a rather high risk. Now, you can understand it in a somewhat, one of the hardest things to measure or to even see are things that don't change. Well, this is very traditional. It's been going on for thousands of years. I mean, cooking in India on an open chula has been, forever. So you don't see anything changes. It can't be important. And, it takes some rather sophisticated statistical analysis actually to dig out the health effects. But now we recognize they're big. I mean, that's the generous explanation for why people haven't looked at it this much in the past. Of course, the less generous one is that these are the people at the absolute bottom of the pyramid. I mean, not only poor, rural, but women. They're at the bottom of the economic and political pyramid. Of course, organizations that we've been hearing about, like SEVA, are trying to fix that and are accomplishing some changes. So this is an organization that deals with the gender aspects of energy. If people are interested and not familiar with it, called Energia. You can get it right off the web. They've done this book, in fact, with the UNDP on gender and energy for sustainable development, a toolkit for thinking about it, if you you're interested, or some students are. So last, a question for the conference. So instead of waiting for them to give me a question, I'm going to give them a question. Cook is probably the most prevalent gender-specific but non-biologically determined task today, and perhaps in human history. I mean, obviously, childbirth is gender-determined, but it's obviously biologically relevant. And you may think that a man giving you advice about cooking is no much different than a man giving you advice about childbirth. But do solutions, such as improved stoves and whatever, therefore need to be gender-sensitive. Now, there's an affirmative argument here. The hearth is central to women's social and cultural identities, and any changes must consider these identities in the relationships in order to work. And you can see the argument for that. In fact, SEVA, among its many things it's done over the years, it's implemented many improved stove programs around India, often with community involvement of the women and even making of the stoves by the women. But there's a counter-argument. A better stove need be no more gender-specific than a better refrigerator or a light bulb or bicycle or cell phone. These aren't, we don't have gender-specific refrigerators. They give a good service, and they're marketed to women, obviously, and men, but there's good marketing needed or, product design, but it's not, in the same sense, a gender-specific activity. So I don't know the answer to this, and it's a kind of it is a bit of discussion, let's say, in the stove world these days. So I leave that with you. All my publications and presentations are on my website, which is long and complicated, but you can just Google my name. Thank you very much.
Thank you very much. Do any of the panel members have a question for Kirk? Yeah, Mirai.
Thank you very much, Kirk. It was very interesting. I just had a question. Any ideas on alternatives? We are looking at solar, but it's still, the technology is so expensive. I mean, poor women are outpriced there also. So we go back then to the traditional chula.
Well, I mean, that's a good question. One way, I mean, in a short presentation, we just talk about cooking, but actually cooking is a number of tasks associated with it. I mean, I don't know. I had a student come up to my kitchen when my wife was away, and we went through all the cupboards and stuff and pulled out all the cooking devices. Well, we had several coffee makers, a popcorn maker, a waffle maker, a tea maker. I mean, a microwave and and an oven, and there were 16 cooking devices in the kitchen. We still had a stove, however. So the way I look at solar is that solar can work for certain tasks, and that you can pick off some of these tasks with certain cooking devices. I mean, a rice cooker is a good example. A rice cooker is not. You can't do anything but make rice with it. But in southern India or China or many parts of the world that make rice every day, it's really an efficient way of doing things. Even though it uses electricity, it's quite efficient. So why not pick off that task? That's that much less air pollution, that much less fuel gathering by the woman, and so on. And it's not expensive. So that's the way I look at solar. You can pick off some tasks, but everybody still wants a stove. They want to be able to cook when they want to. And they come home and it's dark or it's raining or whatever. They want to be able to cook. So you still need a stove, but you can pick off some of the tasks with other things.
And I just want to build on that question, which is kind of getting back, Kirk, to your point on whether you need so what is the technology? Do you need a gender-specific technology? And I think one of the themes that we've heard today from both the Vice President and Ms. Chatterjee are really around community engagement. And in fact, one of the questions from the audience talks about her experience in Guatemala, where women, in fact, had alternative stoves, but they weren't used. So this idea of acceptance, not necessarily gender-specific, but the engagement of the community. What are your thoughts on that?
Well, my thought, I mean, I've worked in Guatemala for 20 years, and we have a stove that we introduced 10 years ago, and it's not our stove, but we introduced the best we could find. And we actually instrument our device. In the exhibit out here, there's a display of, we have developed gadgets that you can actually put on the stove and you come down and download it. You actually see how much it's used. So you don't have to ask people. Asking people how much they used your stove is, problematic. They answer according to, well, they want to make you feel good usually. So they tell you, we love it. Well, we have measurements now. And that stove is still, I mean, it's amazing. I was just looking at the data. That stove is still used 90% of the time by the population. And the reason is, it's a very good stove. It meets their needs. They like it. They use it. It's a whole range. If you ask them, they like it for a number of reasons. It saves fuel. The smoke is in there, but it's not their major reason, smoke reduction. It lifts the cooking surface off the floor, so you don't have burns. The kids don't have a risk of burns. That provides surfaces for people to put the pots and things. If it's on the floor, you're teetering on the uneven floor. I mean, a whole range of reasons, but it's not an accident because we did 8 years of pilot work in advance trying to find the best stove for this situation. And the stove was developed indigenously, but it was developed, and then modified and so forth. So, I guess my answer is if you have a really good product that people like, they'll use it. If you don't, they won't. And no amount of gender, not much alteration by giving a lot of training or so forth is going to change that. It has to really, and the surveys in India show that the three factors that make a success of an improved stove, these are recent surveys. For men, it's fuel savings. Because men have to agree too. They're buying it usually. For women, it's time savings. Mm-hmm. Smoke is down there, but it's there, but it's not. No. And the third thing for women, interestingly enough, is modernity. They want something modern. My husband has a cell phone, I should have a modern stove. So now the movement is away from the stoves that look like their grandmother's stove, but look modern and shiny and look like an appliance. I mean, her grandmother didn't have a cell phone, but she likes the cell phone. Grandmother didn't have a light bulb, but she likes the light bulb. So I mean, it's this new sort of, it's a different way of looking at it. And I don't know, I don't work in Africa. I know things are very different in Africa in many ways. But in Latin America and in India, where I've worked at most, I'm beginning to think that we had it wrong in the past, that we should have been focusing on really high service, that people are willing to change their behavior because it's such good service.
No, thank you.
So.
That actually leads me to another question that's related, and it's really to all three of the panelists, which is, and maybe Kirk will start with you and then move to the Vice President and to Mirai, around the engagement of men in these efforts. I mean, clearly around the issue of stoves, how have you seen, I know it isn't specifically your work, but how have you seen men get engaged? And then when we go to Mirai and Vice President, I want to talk a little bit about family planning and teen birth rates and getting family planning out to women and engagement of men.
Well, I think men, I've seen if you're trying to sell the devices, then you have to obviously engage the men because they unfortunately have most of the, control over the money. Another group, however, is quite important, and I know it's true with almost anything you try to do in India, and probably other places too, is the mother-in-law effect. It's not funny. I mean, it's actually a major problem, and the women will. I mean, mother-in-laws tend to be the repository of sort of traditional values, and at least as they see them, and they also, unfortunately, tend to keep their thumb over their daughters-in-law. And you see that my daughter did research in Chandigarh and found that the reason the women weren't taking their iron pills and folic acid tablets, pregnant women, is their mother-in-laws were telling them it was going to cause them to have a girl, not the doctor or the clinic. And the mother-in-laws would actually sometimes throw them away. So you have to look at, I guess, all the people engaged in the decision making and make sure they're comfortable.
Thank you. Vice President, can you say a little bit about teen pregnancy and family planning and how you've engaged not only the women but also the men?
I was also going to just comment on the male involvement. I have found in our case that it still boils down to the use of the local leadership. Mm-hmm. When the chief in the village encourages the young men in that village to get involved, even to assist or prepare for their wives' delivery, the men will comply. But increasingly in Africa, I think the news of the past 4 weeks will show that our younger men and women are different. And in my particular case, I have found that even in supporting women candidates, the young men between the ages of 17 and 40, men are prepared to support female candidates. So we have two groups of men in Africa now. We have my age group that you have to convince to change, but you have the younger group that are prepared, that are ready to support women's issues. On teen pregnancies, in Malawi, unfortunately, we have 1 million orphans. The majority of those are female, and secondary education is not free. So that is the challenge. So government has had to come up with a special sponsorship program to sponsor the girl child to go to school. Because if she drops out at age 15, which is during the last class of standard 8, primary school, then obviously the community pressurizes her to get married, because that's the only thing to do. And then she has a child at 15 and ends up dying giving birth, or ends up with the serious complications due to childbirth. So the government has come in with special programs that to pay school fees for the girl child from Form 1 to Form 4. Private institutions too, like the Joyce Banda Foundation, is sponsoring 2,000 girls to go to school. It's basically looking at the fact that the girl child needs to go to school for her future well-being. But for us, it is the health connection as well, to ensure that she stays in school 4 more years, so that by the time she gets married, at least she's 19 years old, as opposed to 15.
Thank you. And our last, Mirai, I'm going to ask you to comment last, and kind of maybe in the framework of not only the inclusion of men, obviously, who are going to be working with women around the new policy changes, but in the context of family planning.
SEVA being a women's organization, in the early years, we focused much more on women. And again, it was the women who said, why don't you talk to him? You've been talking with us all the time, but I mean, this subject is such that he has to be involved. And in our country, because these sort of issues are not easily talked about across gender barriers, so we actually had to develop a team of kind of sympathetic and sensitive husbands, fathers, and brothers who would do the kind of outreach work. And we really were very, very pleasantly surprised. Not only were they very interested, but they were ready to take up this role. And, well, the role being talking on a whole range of issues, not just family planning, but also on women's health, on maternal mortality, on taking decisions quickly for women's survival. But since the question was about family planning, also addressing issues like the use of condom, which initially was hardly used, and now it's much more widely used, partly also, not only because of SEVA, partly because there have been a lot of government campaigns, health education campaigns. But I think we still have a way to go. I mean, one of the indicators every month when we look at our health data, we see that still there are women who are going for vasectomy, and hardly any men for the non-scalpel tubectomy, but hardly any men go for NSV, or the non-scalpel vasectomy. It's a big struggle. First of all, it's our own struggle. The women themselves think that, we should do all of this. So we have to get out of that mindset. And then the next leap is convincing the husbands and the sons and the brothers. So, small steps forward, but still a long way to go.
Yep. Well, I want to thank all of you, Vice President Mirai Chatterjee, Dr. Kirk Smith. I think you've really given us a very significant insight into the holistic view of health, that it's not just about healthcare delivery, although that's important, but it's about economic advancement, it's about education, it's about the environment. It's also about involving the community, and it's about activism if we're really going to make significant advances. But I think with the leadership of all three of you, there's definite hope for the future. So thank you very much, and thank you, all of you, for your questions.